It's my great pleasure to introduce Dr. Stephanie Spehar, who's a third-year internal medicine resident here at Michigan Medicine. She received the honor of becoming one of our chief residents this upcoming year, and will be applying for cardiology fellowship shortly thereafter. And she'll be discussing some work she's done over the last year and a half, looking at persistent racial disparities and the risk of readmission and mortality after PCI. Take it away, Stephanie.
Thank you, Dr. Sukol. Like you said, I'm Stephanie Spehar. I'm a third-year internal medicine resident at the University of Michigan, and I'm really excited to be here tonight sharing our findings from this project. I just want to apologize in advance. I'm on the tail end of my COVID illness. I was feeling invincible, but nonetheless, I caught it. So I apologize if my voice gives out a little bit. But like I said, really excited to be here to kind of go over these findings on this project that we've been working with these collaborators from across the state listed here, looking at racial disparities in readmission and mortality following PCI. So as we know, racial disparities in cardiovascular disease management and outcomes are very well established at this point and quite pervasive. We know that Black patients are less likely to be referred for invasive angiography and undergo percutaneous revascularization. Studies on outcomes following PCI specifically have shown that Black patients tend to have worse in-hospital outcomes following PCI, and these differences are often attributed to a higher comorbidity burden. We have fewer studies looking at long-term outcomes following PCI, and those that did have arrived at sort of conflicting conclusions. And understanding this relationship is really important since disparities in long-term outcomes may reflect differential access to healthcare resources, which affect care outside of the acute PCI setting. So the objective of this study is to examine the association between race and 90-day readmission and mortality following PCI in a contemporary data set. And then in an attempt to not only identify disparities, but also understand the mechanisms by which they occur, we specifically wanted to analyze the extent to which various factors mediate this relationship, including personal socioeconomic status, community level economic well-being, and of course, baseline comorbidity burden. So briefly to walk you through some of our methodology, this was a retrospective cohort study using the BMC2 PCI registry data that we linked to Medicare 90-day episodes of care that are available through the Michigan Value Collaborative. After excluding patients who did not identify as either white or Black, or identified as both, we then had a cohort of roughly 29,000, of about which 90% were white patients and 10% were Black patients. And our primary outcomes were 90-day readmission and long-term mortality. I want to spend some time here walking you through our paradigm for understanding this relationship between race and PCI outcomes. So based on prior literature, we proposed that this relationship was mediated by individual socioeconomic status, kind of the economic landscape of the patient and the hospital community, in addition to baseline comorbidities, such that these factors are on the pathway through which race may be associated with post-discharge outcomes after PCI, as you see here. We chose these factors since they're known to kind of track with race and have a plausible association with access to healthcare that decreases cardiovascular risk. And so to explain this framework, we use sequential analyses to successively account for each of these factors when evaluating the relationship between race and post-PCI outcomes. I just want to point out too that we specifically included patient comorbidities last, recognizing that differences in comorbidities kind of at the time of presentation are in and of themselves impacted by race and socioeconomic factors. This table kind of further delineates the measures that we used to represent our proposed mediators. So we first created a propensity score model matching on age and gender, which are considered confounders, and this was sort of our baseline cohort. Next, to account for personal wealth, we included Medicare and Medicaid dual eligibility to the propensity score in cohort A here. Next, to account for the economic landscape of the patient's community, we included the Distressed Communities Index into the propensity model. And to give you some background, this is a validated measure from the Economic Innovation Group. It's a composite score that weighs 7 different economic indicators, including education level, housing vacancy, unemployment and poverty rates, income, job growth, all within a community. And then each zip code receives a rank compared to peers. So for our particular study, we included the zip code of both the patient's community and the hospital. And then lastly, to account for baseline comorbidities, we matched our patients on several clinical and demographic variables in the propensity model. As I kind of alluded to, we've used propensity score matching, and we created a matched cohort in which Black and white patients had similar characteristics, and then used logistic and Cox regression models to assess outcomes by race, such that if a relationship was either attenuated or rendered non-significant by adjusting for those variables, it kind of implies that it at least partially mediates the relationship between race and outcomes. Then to assess the magnitude by which these mediators impacted the effect size, we did a mediation analysis, which I'll sort of describe later. So this table shows select baseline characteristics at the time of PCI between Black and white patients. As you can see here, Black patients were younger, they were more likely to be female, and they were more likely to be recent or current smokers. Consistent with prior studies, we saw that Black patients had higher rates of cardiovascular comorbidities, including hypertension, diabetes, hyperlipidemia, and were more likely to be on dialysis for end-stage renal disease. In this table, we review baseline differences in various process measures and in-hospital outcomes. So Black patients were more likely to be prescribed clopidogrel rather than higher potency antiplatelet agents. And interestingly, Black patients were significantly less likely to be referred for cardiac rehabilitation, which is a really important difference. As you can see at the bottom though, in-hospital outcomes really did not vary too significantly between Black and white patients, with the exception of need for blood transfusions. This figure shows 90-day readmission, so kind of looking at the longer term outcomes now, using the sequential regression models that I previously described. So the figure in the top left corner is our baseline cohort and adjusts for age and gender. And it shows that without accounting for any mediators, Black patients were 1.6 times more likely to be readmitted at 90 days. This relationship was attenuated, but still significant once we adjusted for Medicaid and Medicare dual eligibility in the top right corner here, kind of the measure of personal wealth. Similarly, once we adjusted for community economic well-being using the Distressed Communities Index in the bottom left-hand corner here, it was attenuated, but still significant. Notably, once we adjusted for baseline demographics and clinical factors, the relationship between race and PCI outcomes was rendered non-significant. Next, these are Kaplan-Meier curves depicting mortality following PCI by race. Again, in the top left-hand corner prior to matching, Black patients had a 1.4 times greater risk of mortality compared with white patients. This was still significant, but attenuated once adjusting for dual eligibility, again in the top right-hand corner, and community economic well-being in the bottom left-hand corner. As with readmission, once we adjusted for baseline comorbidities, the association with race and PCI was no longer significant. So given that each of these mediators either attenuated or rendered the association between race and mortality non-significant, we considered these to all be partial mediators and kind of be on that pathway between race and disparate PCI outcomes. So then we really wanted to quantify the magnitude by which each of these proposed mediators influenced that association that we saw. So we did this mediation analysis seen here. In the bar graph, we show the proportion of the race effect on readmission and mortality that is mediated by each variable. So on the left-hand side, we look at 90-day readmission, And we see that dual eligibility mediated 11% of the association between race and 90-day readmission. The combination with the addition of community economic status mediated 22% of the association. And then with the addition of patient comorbidities, all variables together mediated about 45% of the association between race and PCI outcomes. Similarly, looking at mortality on the right, Medicare and Medicaid dual eligibility mediate about 21% of the observed association that we see. Dual eligibility combined with community economic well-being mediated about 42% of the association. And then taken together, all three of the mediators account for about 87% of the association between race and 1-year mortality. So our findings reiterate that cardiovascular comorbidities continue to be more prevalent among Black patients. But while a higher comorbidity burden did account for part of this relationship, personal wealth and economic well-being of the patients in the hospital's community were also important mediators in this relationship and kind of partially explain the disparate outcomes that we see. We also saw that in-hospital outcomes did not differ that dramatically between races, with the exception of referral to cardiac rehabilitation, which was substantially lower in Black patients. It really serves as an important opportunity to mitigate disparities. And as kind of Lisa mentioned, is a really critical component of recovery after a myocardial infarction. In terms of what these findings mean for how we provide kind of care in the peri-procedure period, it really underscores the need for longitudinal care to prevent both the development and progression of disease, given the role that comorbidities play in these disparate outcomes. Another really important piece to these findings, though, is recognizing that there's kind of a complex relationship between socioeconomic status and health outcomes. And it's really likely bidirectional, such that if you're in a lower socioeconomic status, that kind of portends worse health. But at the same time, having chronic illness can also sort of undermine financial security, especially within communities of color. So while we've tried to account for this with our multiple mediator approach, it's really possible that we still overestimated the impact that comorbidities alone have. And lastly, I think our findings showing that in-hospital outcomes between races are similar, yet we see disparate long-term outcomes, highlights that there's an important opportunity to improve disparities outside of the acute hospital setting. And this likely reflects the fact that social determinants of health are chronic and cumulative, and Black patients do experience a higher burden of detrimental social determinants of health. So we really need future studies to determine how we can improve care processes post-discharge to address these disparities.